Okay, good morning, everybody. My name is John Pellerito. I practice at the Northwell Health System and work at the Zucker School of Medicine at Hofstra Northwell. My topic is ectopic pregnancies, the usual and the unusual. For the next few minutes, I'm going to discuss the features of common ectopic pregnancies that we may see in the fallopian tube, and then we'll discuss some of the different types of ectopic pregnancy that you might see. We'll discuss the issue of whether you have a cornual or an interstitial or an angular pregnancy, what the differences are and how you should report those, and also try to be able to distinguish between ectopic pregnancy and a corpus luteal cyst. So important to recognize the definition of ectopic pregnancy is a pregnancy that is not in the endometrial cavity. Any pregnancy that you do not see within the endometrial canal should be considered an ectopic. So ectopic pregnancies represent about 2.5% of all pregnancies. They're the leading cause of pregnancy-related death, about 9%. And most are due to abnormalities of the fallopian tube, whether it be due from scarring or blockage of the tube. And we know that the majority are in the tube. Very important to recognize and ask for risk factors when you evaluate your patients. Anything that causes obstruction or scarring of the tube, as I mentioned, is going to be a major risk factor for the formation of ectopic pregnancy. This can be related to prior surgery or tubal ligation, previous ectopic pregnancy, a history of infection, or endometriosis. And of course, when I see my patients, I always try to elicit that history when I evaluate them because that increases my risk of the possibility of an underlying ectopic. Other risk factors include in vitro fertilization, prior cesarean section. Some associations include the use of an IUD and smoking, and progesterone-only contraceptives. We do know there's an increasing incidence of ectopic pregnancy, and this is related to improved treatment of infection and ectopic pregnancy, which again causes scarring of the tube. And there's also an increased incidence of patients who receive assisted reproductive treatments, such as IVF and IUI. Of course, one of the things we like to have when we do these evaluations is the serum beta HCG. If you work in a hospital, that information isn't always readily available, and you may have to make a determination before that HCG level is known to you. If we do have that information, obviously any abnormality in the HCG, whether it's a slow increase or a decrease, is suggesting an abnormal pregnancy. It's important to recognize that non-viable pregnancy is much more likely than an ectopic pregnancy when the HCG is less than 2,000 and you don't see a sac. But nevertheless, we need to exclude the possibility of ectopic pregnancy. Another thing to remember is that the sonogram can be normal in at least a quarter of patients with ectopic pregnancy, particularly when we see them very early. And in my practice, we see patients 5 weeks after the last menstrual period, not much to see at that point, including ectopic pregnancy. So many times we will have a normal sonogram, and we have to follow that patient until we find that there's evidence of an IUP. So here in the diagram, you can see the different sites of ectopic pregnancy. Again, the vast majority are going to be identified within the fallopian tube, usually in the ampullary region, but they can occur elsewhere within the tube. And we'll spend a few minutes talking about the interstitial ectopic. We can also identify ectopic pregnancies in other locations, and we'll spend a few minutes this morning talking about the possibility of a cervical ectopic or an intraovarian ectopic, an intraabdominal ectopic, or a cesarean scar ectopic. These are all possibilities that you may encounter when you see patients who present to the emergency room with pain, bleeding, or a positive pregnancy test. So here are the classic sonographic findings. Typically, the patient will have an empty uterus, although it is possible to see fluid or an abnormal sac-like thickening within the endometrial canal. In the Adnexa, we look for an ectopic sac or an adnexal mass. Those are the most common findings that you'll encounter. Outside of the uterus, uncommonly you'll see a live extrauterine embryo. That's less than 10% of the time. And there's usually some free fluid, although again, that's fairly nonspecific. If you look at an analysis of the different criteria, you see that a complex adnexal mass, whether it's ring-shaped or solid, is really the most common thing that you see. It's fairly sensitive, obviously, if you see a live extrauterine embryo or an adnexal ring, that's very specific for an ectopic pregnancy. There was a study that was done last year looking at the different ultrasound sites for a tubal ectopic, and you can see that according to the analysis, an empty uterus, a pseudogestational sac, and an adnexal mass with free fluid have limited sensitivity but very good specificity in the absence of an extrauterine pregnancy. Let's take a look at this case first. Here's a 24-year-old, presents to the emergency department with pelvic pain, some vaginal spotting, and in many cases, we're going to go right to the vaginal scan, and here you see a sagittal view of the uterus, centered on the endometrial canal. We can see there's no evidence of any fluid or evidence of pregnancy in the cavity. And we look at the adnexa. Here's the left ovary, and we see a cyst on the left. And then we take a look at the right side, and here's the right ovary, and you can see some follicles on the right. And you have to take a very careful look at both adnexa. And here we could see the right ovary, and here if we take a look, we can see a tubal ring adjacent to the right ovary, and that's the location of the ectopic pregnancy. So training our eyes, training the sonographer to identify tubal rings is really important, because this is something that really is an Aunt Minnie for the diagnosis of ectopic pregnancy. Here's another example of a tubal ring. It looks like a donut or a lifesaver. In this particular case, we even see that there is a yolk sac contained within the intrauterine gestational sac. So it gives you 100% specificity that you have an ectopic pregnancy. Here's some more examples of tubal rings. One of the things I want you to notice right up front here is the echogenicity. And we'll talk a little bit about that, again, toward the end of the presentation. But notice how the echogenicity of the sac tends to be brighter than the adjacent ovarian tissue. And that's an important clue, because many times the ectopic pregnancy is located adjacent or apparently within the ovary. And that can be tough to determine. Well, are we dealing with a corpus luteal cyst, or are we dealing with an ectopic pregnancy? So echogenicity is one of those important clues that allow you to determine this is more likely to be an ectopic pregnancy. Here's another 24-year-old patient, presents with pelvic pain, positive pregnancy test. We're looking at a sagittal view of the uterus. The endometrium looks slightly thickened. Again, now we're looking in the left adnexa, and we see that echogenic tubal ring, again, allowing us to make a specific diagnosis of an ectopic pregnancy. Notice that there's a fair amount of blood adjacent to it because it's a leaking ectopic, partially ruptured. On occasion, we will see the live ectopic pregnancy. Here we see a large adnexal mass, and we can see an embryo, and in real time, we see cardiac activity, and you can document that either with a video clip or with M-mode, as we do in this particular case, showing the cardiac tracing, showing that it is a live ectopic. One of the pitfalls of this exam, and I've seen this before, if you're not careful, you might actually mistake this as the uterus and think that this is an intrauterine pregnancy, especially if you have a large ectopic and the uterus is displaced to the side. You may see this in the midline and say, oh, here's the uterus, here's an IUP. And that would obviously be a bad mistake to make. Another pitfall is when we don't see the tubal ring and we mistake sometimes large masses because we're not thinking ectopic pregnancy. Here's a patient that has a large clot sitting in the fallopian tube, so-called Hematosalpinx. And it's just distended with blood because the ectopic has ruptured. And again, I've seen this missed because people are looking for rounded masses, not paying attention to the fact that we do indeed have this echogenic mass sitting in the adnexa representing the location of the ectopic. And here's another case that was encountered on call one night. And I came in the morning, and here was a 34-year-old patient, pelvic pain, positive HCG, and it was read as ectopic not found. And if you look at this first transabdominal scan, you can see the uterus, and there's endometrial canal. It's empty, it's normal. You can see a little bit of fluid in the bladder. But what's not perceived at the time of examination is the large mass sitting behind it, which I thought was even more obvious When we did the vaginal scan, again, the uterus is displaced somewhat anteriorly. Here's the endometrium, the back of the uterus, and this large mass sitting behind it representing a ruptured ectopic pregnancy. So paying attention not only to the uterus and the ovaries, but of course, looking around for any abnormality allow you to make that diagnosis. So this was a ruptured ectopic and a large pelvic hematoma. I'm going to talk just a little bit about how we use Doppler to help us make the diagnosis. And Ken Taylor showed many years ago that with the growing placenta, there's invasion of the uterine tissue into the endometrium with shunting of blood across the intervillous space because the growing chorionic tissue invades into the maternal spiral arteries, and you get shunting of blood into the intervillous space. And you can appreciate this increased blood flow early on. You can see it as early as 5 weeks after the last menstrual period. And here's an example of an intrauterine pregnancy, and you clearly can identify the sac and see the increased vascularity. On this old image that was obtained long ago, there's increased blood flow that you can see around the sac very early on, from 5 weeks, and you can place the sample volume on that increased vascularity. You don't need to have angle correction. You could use a 0-degree angle because we can't determine the direction of flow of these vessels. And we have found that a velocity cutoff of 21 centimeters per second, and I ask you to remember that number, it allows you to detect placental flow in the uterus. 21 works very well. And so here's another example. 29-year-old presents to rule out ectopic pregnancy. There's a high clinical suspicion, some blood in the pelvis, and you can see here's a very small sac. It's about 5.5 weeks, but you can see the increased flow around the sac. And if you choose to sample it, which we would not do in a usual situation when we're not concerned about ectopic, but if we need to exclude ectopic pregnancy, you could take a sample, see that the velocity in this case is about 30 centimeters per second, indicating that we have placental flow around that early sac. And that can be helpful to distinguish it from a pseudogestational sac, which is that abnormal thickening of the endometrial canal that we'll see due to the increased HCG that circulates when you have an ectopic pregnancy. So this is not a normal IUP. You don't have a double decidual sac sign. You won't see a yolk sac, and certainly won't see any evidence of an embryo. But you may be confused by its appearance. If you look here on the sagittal view, it can look like a sac. It's seen in up to 15% of ectopic pregnancies. And one of the ways we can distinguish that from an IUP is there will not be any placental flow. So here's another case to illustrate the point. 4 weeks after IVFs, and the HCG is 800. So there's discordance between the HCG level, the timing of the study, and the appearance here of relatively large-looking sac within the endometrial canal. So in this particular case, I turn the color on, I see that there's no flow. I sample around the area and the velocity is only 13 centimeters per second below the 21, which I would expect if this was an intrauterine pregnancy. So now I'm concerned that I'm dealing with a pseudogestational sac and not an IUP. Spend more time on the adnexa, and you can clearly see here's the ovary on the left side, and you can see the follicles, which allow us to determine that that is indeed the ovary. But can you see the ectopic? It's sort of hidden here. Sometimes it's obscured by surrounding hematoma. Sometimes it's obscured by bowel. Sometimes color can help you. And if you turn the color on here, you could see the vessel silhouette, the ectopic pregnancy. Here's that donut located adjacent to the left ovary. It's over here on this grayscale image, but I think it's seen a little bit better that when you turn the color on here. Now, we showed many years ago that we can also demonstrate increased blood flow within the ectopic gestational sac. We did a study, we said we saw this in about 85% of ectopic pregnancies with a fairly high sensitivity and specificity. We didn't feel that a velocity cutoff was helpful in these cases. The velocity cutoff of 21 is valuable in the uterus, but it does not apply to the ectopic sac. But you can indeed show the increased blood flow in the ectopic pregnancy. And again, you will see that low resistance flow pattern because, again, it's shunting of blood into the intervillous space along a pressure gradient. That's why we have lots of forward diastolic flow. And you'll see it even in masses that aren't necessarily ring-shaped. And I think that's helpful in a case like this. Here's a patient with pelvic pain and adnexal mass on the grayscale, which we are very concerned could be an ectopic, though it just doesn't really look like an ectopic. But the increased vascularity within the tissue says, well, what else would it be? Bowel doesn't give you increased blood flow like that, nor does hematoma. So this was the location of the ectopic pregnancy. But we have to be careful, and I'm sure most of you recognize that you also do get increased blood flow in a corpus luteal cyst in a similar pattern. There really is no way to distinguish between a corpus luteal cyst and an ectopic gestational sac just by looking at color, or even by applying pulse Doppler. They will have overlapping appearance. So location is the key. So let's talk about some less common ectopic pregnancies because these do show up at your doorstep and certainly come to mind with some regularity. Here's a 38-year-old, status post-IVF with some vaginal spotting. This is a sagittal view of the uterus. And the endometrium, although not well seen, is seen centrally in this area here. And what do we have? We see what looks like a gestational sac in a very eccentric location. And so what do we call that? I mean, I think we sort of say, well, it looks like it could be a cornual pregnancy. And one of the things that we tend to do for that is try to measure the myometrium around the sac, and we'll take additional views. Here's the transverse view, and again, by definition, a sac that is not in the endometrial canal is an ectopic pregnancy. And here we clearly see it's abutting the edge of the myometrium in this case. And this is truly an interstitial pregnancy. The sac is outside the endometrial canal. So interstitial pregnancies are relatively uncommon, but we will see them. And the problem is because they're associated with significant morbidity and potentially mortality because of the massive hemorrhage if they rupture. There's a lot of concern when you say, well, this could be an interstitial pregnancy. They want to know for sure. They don't want to guess. And then you'll say, well, maybe we'll do an MRI. Well, that may or may not help. So you need to have specific criteria. And one of the things is, if it's not in the endometrial canal, then it's going to be an interstitial pregnancy. These are typically seen very high. They're lateral in the fundus. You can see here in the diagram, outside the endometrium. Some people will measure the myometrium. And if you look in the literature, there's several criteria. I like the one less than 5 millimeters of myometrium around the sac is suspicious. 1 centimeter does not work very well. And some have described the interstitial line sign, which is a line which I think is imaginary in many cases, that shows you that the sac is outside the endometrium. If you can put an imaginary line there, then that, again, is an ectopic pregnancy. Here's another case, 42-year-old with artificial insemination 1 month prior to the study. The HCG titers are not going up normally. And here we're looking at a sagittal view of the uterus, and again, the sac is eccentric. And so the question is this an interstitial pregnancy? And your job is to prove it is not in the endometrial canal, which it's not in this case. Here's a different case, patient status post-IUI, presenting with right lower quadrant pain. Sagittal view of the uterus looks pretty good. In fact, the endometrium is very thin, surprising for a pregnant patient. So we look at the right side, the ovary is good. We look at the left side, that's also fine. Where's the ectopic? So this required a careful transverse scan right down from, the lower uterine segment all the way up. And then we start to notice that there's a bulge that's occurring in the right fundal area. And if you turn the color on, all of a sudden there's this incredible vascularity in that right fundal region. Now, it's possible, you say, well, maybe that's a fibroid. But it could be a fibroid, but you have to analyze it a little bit more to make sure that you're not dealing with an interstitial pregnancy, which is indeed the case here. So this brings up the question, what is the correct terminology? I keep using the term interstitial rather than cornual. And the reason that is because the definition of a cornual pregnancy in the literature is an eccentric gestational sac. And the word was coined to discuss sacs that were in septate uteri or bicornuate uteri, literally in the cornu. It's not synonymous with a pregnancy outside the tube, although we use it that way. When we think that there's an interstitial pregnancy, we say, well, it's a cornual pregnancy. But that's actually not correct. The term interstitial refers to the ectopic pregnancy. And there's one more term that I want you to use if you're not currently using it, and that's angular. And that refers to the sac when it is in an eccentric location, but it is located within the endometrial canal. Now, these are not ectopic pregnancies, and there's uncertain viability because they really have it implanted in a normal location, but they're not ectopic. So let's look at a couple of cases. Here's a patient that presents with an eccentric-looking sac, and this is kind of typical in my practice where we get these sacs that are not midline. And then, you know, of course, everyone is concerned. Many of these were scanned in an outside practice or in a GYN group, and they say, well, you know, JP, is this a cornual pregnancy or an interstitial pregnancy? And so we have to look at it. And this is where 3D can be very helpful. Because when you do your 3D, you can say, oh, wait a minute, no, this is located within the endometrial canal. This is really an angular pregnancy. It's not an interstitial pregnancy. So this is one of those situations where 3D can be very helpful because you want to see the endometrium covering the sac. Here's a 35-year-old with vaginal bleeding. Again, on the transverse view, very eccentric. And if you look at the endometrium, it's far away from the sac. And if you look at the sagittal view, you say, well, it's right next to what looks like the endometrium, so I'm really not sure. And in this case, again, 3D was very helpful to me because I could see, oh, it's an arcuate-shaped uterus. The sac is really within the endometrial canal. This is really another angular pregnancy. This is not an ectopic pregnancy. And as you know, when you perform these types of cases, the level of anxiety, not only for the patient, but for the referring doc, is going to be very high if you say, well, I'm really not sure. How about this one? Is it cornual? Is it interstitial? Is it angular? Now, here it looks like we have fluid within the endometrial canal here, and then again on the other side we see a gestational sac with an embryo. And so, you know, getting a coronal view shows that what we're really dealing with here is a septate uterus. And the reason that we have duplication of the canals is that septum coming down from the fundus. And you can see that with a bicornuate uterus as well, where there's a defect at the top and there's divergence of the canals. And again, on a transverse view, it's going to look like the sac is separate from the endometrial canal, but in this case, we have a duplication of the endometrial canals. And here's a case that was lent to me by Sandra Allison, where she had a case of bicornuate pregnancy with twins, one in each canal, which can also occur. So we talked about that distinction. Now, there are other cases where things can be a little bit confusing. Here's a 35-year-old with pelvic pain and positive pregnancy test. And we notice in this particular case that the sac is extremely low in the uterus. And this is a transabdominal view. And here's the fundus. And you can see the sac is all the way down here. And when we do the vaginal scan, we can see, wow, this is really low. This is really bulging into the cervical canal. And then in this particular case, you can see there's a yolk sac, there's an embryo, there's a heartbeat. So what we're really dealing with here is a cervical ectopic pregnancy. And yes, they're relatively uncommon, but like the interstitial pregnancy, high risk of significant hemorrhage. Risk factors would include a prior abortion or instrumentation in that area. We would look for evidence of a gestational sac or an embryo, and the differential diagnosis includes a spontaneous abortion where the sac is moving down into the canal. And the only way you can really prove that is by having prior studies, seeing the movement and seeing the absence of a heartbeat. Now, this is something I pulled from the literature, and unfortunately I don't have the reference for it, but it was so unusual. This was a patient that presented with right upper quadrant pain, and here we have a coronal MR and a sagittal ultrasound image of an intrahepatic ectopic pregnancy. I've never seen this, but it has been described in the literature, and you can see here on the ultrasound that we have a fetus with a head and body and extremities located above the level of the kidney, inside the right lobe of the liver. And abdominal ectopics, again, very unusual. They can be seen in the pouch of Douglas or in behind the uterus. They're considered to be a result of a tubal ectopic pregnancy that was extruded and is loose in the abdomen, usually settles on the peritoneal surface, but somehow may get inside the parenchymal tissue of the liver or the spleen or within the omentum. Now, here's a patient with vaginal bleeding and trying to determine if there's viability of the pregnancy. And again, here we have a sagittal view and another low-lying gestational sac. And here we take a close-up view and we notice that the sac is not really in the cavity. The sac is located up against the anterior myometrium in the lower uterine segment. And that is the classic location for a cesarean scar pregnancy. And this is getting a lot of attention lately, partly because we're seeing more of them and making the diagnosis earlier, and partly because it's a treatment dilemma. Because, you know, is it going to really grow into the cavity, or is it going to expand and cause rupture of the uterus? And I know from my referring docs that they're really not sure what to do with many of these cases and feel that perhaps treatment early is the way to go to avoid a significant complication. So these pregnancies implant within the myometrial defect of the cesarean section scar. And as you know, there's an increased risk of bleeding and certainly uterine perforation if these things were to grow. And there's also a significant risk of placenta accreta as they invade into the myometrium at the site of the scar, with a risk up to 40%. Here's a couple of more examples. And you can see here, this one is implanted within the scar. And many of these cases, it's almost impossible to measure that anterior myometrium. It is so thin, and it has that worrisome appearance that basically that the sac is growing right through the wall of the uterus. And here's a corresponding MR. And I don't know that the MR necessarily gives us more information. It just gives us pretty images. Here's another example of a cesarean pregnancy. Again, notice the bulging along the anterior vaginal wall down at the lower uterine segment. And here's another one bulging anteriorly, worrisome appearance, and there's the corresponding MR. Here's a different patient. The HCG was 4,000. So at 4,000, we know we should be seeing an intrauterine sac. Patient is asymptomatic. Sent over by the high-risk group, and here's the sagittal view of the uterus showing no evidence of a sac within the endometrial canal. So we turn our attention to the adnexa. Here's the left ovary. The left ovary is well characterized by the peripheral follicles. We don't see anything there. And then we go over to the right adnexa, and here's the ovary. And then here we have what looks like some cystic mass projecting from the right ovary. And again, I think, as with many of these cases, I'll ask you to pay attention to the echogenicity. I think that can be helpful. I will tell you in this particular case, I could not budge the cystic mass from the ovary. It looked like it was part of the ovary. Certainly ovarian tissue had a claw around this, so it looked like it was likely intraovarian. Patient was asymptomatic, so I said, I'm a little bit concerned about this. There's no IUP. I see no other evidence of an ectopic pregnancy, and I see this eccentric cystic mass projecting from the ovary. Color showed flow around it, and in fact, those vessels were coming from the ovary itself. And that's where color was telling me that the vascularity to the mass was coming from the ovary. So I said, I guess it could be an exophytic luteal cyst, but it did have an echogenic appearance. And so we followed it for another week, and the patient started to develop symptoms of right adnexal pain. They also started to develop a little bit of free fluid. With seeing no other evidence of ectopic pregnancy, the patient went to surgery, and this was an intraovarian ectopic. So these are thought to occur when the egg is not extruded from the follicle and is fertilized within the ovary. Again, very uncommon and associated with pain and bleeding, and again can cause significant hemorrhage. Typically treated with surgery, methotrexate. I'm not sure how well that works, but that has been proposed. One last type that I want to make sure that you guys consider when patients present. Here's a patient who's 31 years of age, positive HCG pelvic pain. Sagittal view of the uterus shows a well-defined intrauterine pregnancy. We could see a very small embryo. There's a yolk sac, Looks pretty good. The only problem with this particular case is if you look behind the uterus, there's a mass. Now, what could the mass be? Well, you know, there's other things that you can have masses in the pelvis, right? One of the more common things that I see in pregnant patients is dermoids. And I think you need to consider the possibility of having a dermoid in a young patient that's pregnant, but this is located behind the uterus. And you can see there's a little bit of free fluid there. And then when I look at the cul-de-sac, there's a lot of blood. So now I'm really concerned about the patient, and you know, because of the fact that they had ART, you know, this could be an ectopic in addition. And I'm looking around, here's the right ovary, lots of follicles. Here's the left ovary, a lot of free fluid. And then as I look further along the right adnexa, I see this large echogenic mass. So I see here that this is likely a ruptured ectopic in the face of someone with an IUP, so we're dealing with a heterotopic pregnancy. Here's another example of a heterotopic pregnancy, and here's a gestational sac in the adnexa. And this is something also to consider in patients who've had assisted reproductive therapy. The frequency, you know, was thought to be 1 in 30,000, but now we know it's closer to 1 in 2,000 in patients who do get IVF or IUI because multiple embryos are transferred. So there's a greater risk of having multiple pregnancies, particularly if patients have underlying tubal disease. So I want to finish up with a couple of cases. And again, these are things to consider when you're not sure what you're looking at. And here's a patient that had an LMP 3.5 months ago. So obviously that doesn't fit very well. The HCG is 5,000 and we're ruling out ectopic. So we're looking at the uterus, transabdominal view, endometrium looks fine. And you may be asking, why do I do all this transabdominal imaging? And the answer is, I'm looking for masses that are outside the field of view in an endovaginal scan. Many times I find things on the transabdominal scan I do not see on the vaginal scan alone. So I typically will augment that, particularly in patients when I'm ruling out ectopic or patients with large pelvic masses like fibroid disease. It can be very helpful. Right ovary looks okay. Now we look at the left adnexa, and there's a cystic lesion on the left adnexa. And it's got increased flow around it. So the question is, am I dealing with an ectopic here, or am I dealing with an ectopic pregnancy? Remember, the HCG is 5,000. Now take a look at the grayscale image. Remember, we talked about echogenicity. And one of the things that we learned through time is that the echogenicity of the ectopic pregnancy is typically greater than the ovarian parenchyma. Here's a study that came out years ago by Mary Freitas from the Brigham. Here's another study that came out from Marjorie Stein in New York. And in both of these studies, they found that in the majority of cases of ectopic pregnancy, the ectopic tends to be more echogenic than the surrounding ovarian tissue. And I find that to be very helpful. So going back to this case, do we think it's an ectopic or do we think it's a corpus luteum? Well, looking at the lesion, it's less echogenic than the adjacent ovarian tissue. So I think it's probably more likely to be a corpus luteal cyst. And then I spend more time going back to the uterus and I see that there's and this is a magnified view of a very small intrauterine pregnancy. Finally, just a point about mobility. Now, many times, and here's a good example. Here's the ovary, and here's this little lesion right next to it. Is it part of the ovary, or is it separate from the ovary? And here's a study that came out in GAUM years ago that said, you know what, if you gently press on the mass while you're doing the scan, and you can separate the lesions, then you can prove that it's not an ectopic pregnancy. And in this particular example that I've done, you could see here that as I press on it, I can actually displace gently the ectopic pregnancy from the ovary, proving to myself very quickly that this is an ectopic pregnancy. Here's just another example. 34-year-old with pain and vaginal bleeding, retroverted uterus, which can make the examination a little more challenging. Here's the endometrium, no evidence of an IUP, and I'm looking here at the left adnexa. Ovary is here, and there's a mass right next to it. Looks like it's part of it. One of the clues here is a little bit more echogenic than the ovary, so that makes me a little suspicious. And I gently press with my free hand as I'm scanning, and you can see here, here's the ovary, that I can gently displace it from the ovary, proving that is an ectopic pregnancy. So I'm going to conclude here. The incidence of ectopic pregnancy is increasing. Always important to elicit risk factors from the patient because that can increase your suspicion that something's going on. Obviously, getting as much history, knowing what the ECG information is when you do the vaginal scan can be very helpful in your diagnosis. And when in doubt, just recommend a close interval follow-up so you make sure you preserve normal early intrauterine pregnancies. Thank you for your attention.